We are live now.
Good morning, everyone. Diet is the essential key to all successful healing. Nutrition is the only remedy that can bring full recovery and can be used with any treatment. Food is our best medicine. Good morning once again. I am Ms. Kalyani Singh, Assistant Professor, Department of Home Science, Postgraduate Government College for Girls, Sector 42, Chandigarh, as well as the Executive Member of the Indian Dietetic Association, Chandigarh chapter. And I welcome and thank you all for joining today's webinar. I, on behalf of the Department of Home Science, Postgraduate Government College for Girls, Sector 42, Chandigarh, and Indian Dietetic Association, Chandigarh chapter, welcome you all to the national webinar on reversal of diabetes and carbohydrate counting to mark the World Diabetes Day 2020, which falls on November 14 every year. We have amongst us our speaker, Mrs. Shilpa Joshi, Director, Mumbai Diet and Health Center, Professor Dr. Nisha Agarwal, Principal, Postgraduate Government College for Girls, PGGCG 42, Sector 42, Miss Sulita Malhotra, Chief Dietitian PGI, as well as convener, Indian Dietetic Association Chandigarh chapter, and Dr. Manpreet Kaur, Head Department of Home Science, PGGCG 42. I request our the principal ma'am to kindly welcome our speaker and participants. But before that, Professor Nisha Agarwal, former principal of Government College of Commerce and Business Administration, Chandigarh, needs no introduction. She has competent experience of handling college administration and financial duties. She has an experience of about 35 years and has the ability to train teachers to do their best. With excellent communication and interpersonal skills, ma'am is an expert in preparing college curriculum and managing student relations. Professor Agarwal has co-authored a number of books on subjects like financial market at institutions, financial services, etc. She has published many research papers in different journals and presented papers in various national and international conferences. Over to you, ma'am.
Good morning, everyone. I welcome you all to the national webinar on reversal of diabetes and carbohydrate counting, an endeavor by our college to raise awareness about the importance of quality nutrition for good health. World Diabetes Day is celebrated on November 14 to mark the birthday of Sir Frederick Banting, co-discoverer of insulin drug along with Charles Best. It is the largest diabetes awareness campaign which draws attention to the various issues of paramount importance so that requisite actions can be taken up to cope up with the critical global health matter of diabetes. This year's theme for World Diabetes Day is the nurse and diabetes. The campaign aims to raise awareness about the paramedical staff who plays such a crucial role in supporting people with this ailment. The paramedical staff not only includes nurses but all the healthcare providers like nutritionists, dietitians who help the diabetic patients in maintaining optimum quality of life. It is essential that the government takes key interest in the education and training of workers. This webinar has been designed in consonance with the theme of the important role of nutritionists and dietitians in the management of diabetes. It is pertinent to educate one and all with the basic knowledge of how type 2 diabetes, a non communicable disease, can be reversed by maintaining proper lifestyle and nutrition. And to speak about the topic, I welcome our speaker, Ms. Shilpa Joshi, Director, Mumbai Diet and Health Center, who will be enlightening our participants. On this note, I once again wholeheartedly welcome everyone attending this webinar. Thank you.
Thank you, ma'am. I now request Mrs. Sunita Malhotra, dietitian at Postgraduate Institute of Medical Education and Research, as well as convener, Indian Dietetic Association Chandigarh chapter, to kindly introduce the theme to our participants.
Thank you, Kalyani. A very good morning to one and all. At the outset, I would like to congratulate Dr. Manpreet, Ms. Kalyani, for taking the initiative of organizing this webinar under the able guidance of Professor Dr. Nisha Agarwal, Principal Government College for Girls, on the very important topic for the forthcoming World Diabetes Day falling on 14th of November. So, just a brief about diabetes. As we all know, diabetes is a common lifestyle chronic disease requiring lifelong treatment, and it is associated with several macrovascular, microvascular problems, and which can result in cardiovascular, renal, or neurological complications. And if we see the prevalence, there has been an exceptional rise in diabetes worldwide, and India is no exception. And if we go we see the statistics. According to 2019 International Diabetes Federation statistics, there are approximately 463 million people with diabetes. And the number is going to rise to 578 million by 2030 and 700 million by 2045. It's very alarming. And India, there are around 76.9 million people with diabetes. There can be two different types of diabetes, type 1 diabetes or type 2 diabetes, or diabetes occurring during pregnancy called gestational diabetes. So basically, type 1 diabetes is an autoimmune disease in which the body destroys the cells in the pancreas that produce insulin, which means type 1 diabetes do not make insulin, and hence the body cannot regulate the amount of glucose in the blood. Whereas in type 2 diabetes, people develop a decreased sensitivity to insulin, which means the body doesn't make or use as much insulin as it can. And it is mainly caused by excess yet reversible fat accumulation in liver as well as in pancreas. So excess fat worsens hepatic responsiveness to insulin, leading to increased glucose production in the blood. So type 2 diabetes is more common, more widespread than type 1 diabetes. And the management of diabetes is multidisciplinary. A healthy eating pattern and regular physical activity are pivotal to diabetes management. We see the medical nutrition therapy plays a very important role in preventing diabetes, managing existing diabetes, as well as slowing the rate of development of diabetes complications. So, an individualized medical nutrition therapy program by a registered dietitian is recommended for all diabetic patients, whether type 1, type 2, or gestational diabetes. So, now coming to today's topic of webinar, that is reversal of diabetes and carbohydrate counting. So, as we all know, diabetes has been identified as an incurable, chronic, yet manageable medical condition. And various studies also show that it is possible for some people with type 2 diabetes to reverse it. So, reversing diabetes is a term that usually refers to long-term improvement in insulin sensitivity for people with type 2 diabetes. So people can reverse the symptoms of type 2 diabetes by adhering to special lifestyle changes that includes improving their diet as well as through exercise. Also, as per recent 2016 World Health Organization global report, wherein it has shown that diabetic reversal can be achieved through weight loss as well as through caloric restriction. And people with type 2 diabetes who are able to get their HbA1c below 6% without taking diabetes medications are said to have reversed or resolved their diabetes. It has been also shown that various evidence-based studies that effective ways to reverse diabetes includes low carbohydrate diet, very low calorie diets, exercise, as well as bariatric surgery. So low carbohydrate diets reduces liver fat, helps in lowering the amount of insulin the body needs to produce, which results in less insulin resistance. Whereas very low calorie diets have been shown to achieve significant weight loss, decreased insulin resistance, and helps type 2 diabetes to come off their diabetes medications. It has been also proved by the community-based cluster randomized trial, diabetes remission clinical trial or direct, which showed that 46% of people with diabetes could achieve reversion at 12 months and 36% at 24 months, which was mediated by weight loss. So, exercise or increased physical activity is also helpful in reversing type 2 diabetes combined with reduction in calorie intake and weight loss. If dietary changes and exercise are not possible or successful, a person can also achieve weight loss through bariatric surgery. And various significant studies also indicate that in diabetes type 2, reversal is achievable using bariatric surgery through the technique of bariatric surgery. So, other very important part of diabetes control is carbohydrate counting. Carbohydrate counting is one form of meal planning that diabetes people can use to help manage their blood glucose levels. So, carbohydrate counting is planned for diabetic patients with main focus on balancing carbohydrate food choices throughout the day to manage blood sugar levels. So it also involves keeping track of the amount of carbohydrate, the amount one eats or drinks each day. Carbohydrate counting also ensures variety and flexibility in diet and encourages the individuals to follow his or her traditional diets even. Various scientific organizations, American Diabetes Association, health professionals use carbohydrate counting to teach patients to control their blood glucose levels. So, without taking much of a time, to know all the intricacies of reversal diabetes, carbohydrate counting, can diabetes of any duration be reversed, or how carbohydrates are measured or calculated? To discuss everything in detail, we have a very eminent and a renowned personality with us, Dr. Shilpa Joshi, who is the Director, Diet and Health Center, Mumbai, who will be sharing her views with all of us. So, may I request Dr. Manpreet to introduce our speaker, Dr. Shilpa Joshi, please. Over to you, Manpreet.
Thank you, Mrs. Sunita. Good morning, everyone. As we already know that the World Diabetes Day is being celebrated on the 14th of November, and it is a globally celebrated event to increase awareness about diabetes. So today's webinar is just a small step in this direction. And the theme for this year is the nurse and the diabetes, where we need to celebrate all the paramedics, whether it is the nurses or the dietitians or the nutritionists, who have a huge role to play in supporting people living with diabetes. And awareness about this disease is all the more important because it comes with a huge burden of serious complications. So, the main idea is to prevent it. And this year, coincidentally, the World Diabetes Day, it happens to fall on the same day as the Festival of Lights and Sweets. Deepavali is just round the corner. And I'm sure Ma'am Shilpa Joshi will have some important tips for managing the blood sugars during this time of festival too. So can diabetes only be managed or it can really be reversed? So if yes, then the big question is how? And so to talk about this topic, reversal of diabetes and carbohydrate counting, it is my pleasure to introduce to you the speaker of the day, Mrs. Shilpa Joshi. It could not get any better than to have Mrs. Joshi herself to speak about the topic today. And I'm really happy to share with all of you that incidentally today it happens to be our speaker's birthday. So, from the entire fraternity of PGGCG 42 and IDA Chandigarh chapter, ma'am, we wish you a very happy birthday. Thank you for being so kind and gracious to accept our invite for the talk on your special day. And may you continue to heal the lives of people who come in contact with you. So, coming to the many feathers in the cap of Mrs. Joshi, she is the director of Mumbai Diet and Health Center. She is also a very astute practicing dietitian and a diabetes educator. She also holds the prestigious post of the Vice President of the Indian Dietetic Association. She is also the Honorary Secretary of the All India Association of Advancing Research in Obesity. She is the Master Trainer for the Diabetes Conversation Maps. She is the course director of the National Diabetes Educators Program and has trained more than 3,000 diabetes educators in the country. She has presented at various national and international meetings, including the prestigious American Diabetes Association, International Diabetes Federation, and International Confederation of Dietitians. She is the runners up recipient of Wimheimer and Guggenheim International Essay Award in 2017 of the Academy of Nutrition and Dietetics Foundation on Malnutrition. Ma'am, we are all waiting eagerly for an enlightening session from you, and it will be an absolute honor to listen to you. So it's over to you, Mrs. Shilpa Joshi.
Can you see the screen? Hello? Are you able to see my screen? Hello? Hello? Hello, can you hear me? Hello? Can you hear me?
Yes, yes.
Hello? Are you able to hear me?
Yes, ma'am, we can hear you.
Okay, now let me share the screen.
Okay.
Can you see the slides? Hello?
Yes, ma'am. Yes, ma'am, we can see the slide. Yes, yes.
Okay. Okay. So, dear friends, also thanking Dr. Manpreet, Dr. Kalyani Singh, Sunita Malhotra from the IDA, Indian Dietetic Association, Chandigarh chapter, and Dr. Nisha Agrawal. Thank you so much for having me here. Now, we have heard from Dr. Sunita, from Sunita ji and from Manpreet about, everything about World Diabetes Day, that it is birthday of Dr. Banting. And therefore, in his honor, not only is 14th November celebrated as World Diabetes Day, but also the month of November is celebrated as Diabetes Awareness Month. And we know that there is a rising rising prevalence of type 2 diabetes across the world, but India has the dubious distinction of being number 2 in the amount of people with diabetes globally, the first rank being of China. And therefore I think awareness about diabetes in India to everybody, not only to the nutritional professionals or nursing professionals or doctors, but awareness of diabetes among common people is very, very necessary, and it will go a long way in prevention. Now, today I'm going to be talking about something very, very interesting, which is called as reversal of type 2 diabetes with nutrition. And this is something, as a dietitian, I'm sure Sunita also gets such patients who come to us with a lot of hope and they say कि मैडम ठीक से परहेज किया तो क्या डायबिटीज ठीक हो जाएगा? Yeah, will we be able to get rid of type 2 diabetes? And this is the story which I want to tell you. So this is the IDF 2017 data on prevalence of type 2 diabetes across the world. And you will see, if you look at India, look at it, it is among the red zones in the world. So we have very, very high Southeast Asia, 1 in every 5 adults is with diabetes in urban region, and 1 in 4 live births are affected. with hyperglycemia in pregnancy, and that's a huge number. So this is indeed a growing epidemic. In 2015, 1 in 11 individuals were diagnosed with diabetes, and by around 2040, 1 in 10 individuals will be diagnosed with diabetes. And these are people across the world with undiagnosed diabetes. My firm belief is that, once the disease is diagnosed, at least one can be aware and one can manage it. The bigger problem lies when the disease is undiagnosed, and that is the biggest problem with diabetes, because as such, diabetes shows no symptoms. So if somebody has hyperglycemia, there is no way of others to know whether there is truly hyperglycemia, because all the osmotic symptoms which are associated with type 2 diabetes happens much later when sugars are very, very high. But the rate of complication increases right at the HbA1c of 7.5 when sugars are not really that high. And you will see in India, the number of people with undiagnosed diabetes is about 42.2 millions, which is about 57 to 60% of people are actually undiagnosed. And that is the bigger problem. And these are top 10 countries or territories for number of people with diabetes between 2017 and 2045. And you will see that India is among the top. So this is not one place where we want to come in top, but we are at the top. And so much for the westernization of the economy or westernization of diet. If you actually look at the countries, there are very few countries here from the real Western world except United States. So if you look at it, United States has a higher prevalence of diabetes, but in the Europe, the prevalence of diabetes is much lower. Other countries, look at Germany. Germany is also at number 9. Russia is at number 7, but other countries are actually developing economies of Brazil, Mexico, Indonesia, China, so on and so forth. Okay. So in Southeast Asia, if you see the atlas, you will see that we have greater than 9% of prevalence. So at a glance, you will see that in India, there are so many people with diabetes, and the male to female prevalence is not very different. At the age between 60 to 69, you will see that the prevalence is almost same. Only in 50 to 59, there is considerable difference between males and females, but otherwise there is prevalence among both men and women. So what are the highlights? Southeast Asia is home to 1/5, that is 19% of total number of people with diabetes in the world. Remember, our health budgets are not so huge to tackle these people. Almost 84 million people have diabetes, the second highest regional number. And if we do not act on this now, figure will rise to 86% by 2045. More than half of them have not been diagnosed and are at higher risk of developing harmful and costly complications. 1 in 12 adults have diabetes. With 1.3 million deaths in 2017, the region has second highest numbers of deaths that are attributed to diabetes in any of the IDF 7 regions. 1 in 4 live births is also affected by hyperglycemia in pregnancy. However, the region has second lowest related diabetes expenditure per person, totaling to about US dollar 9.7 billion. So look at the gross difference. We have the second highest number of the world, but we have the second lowest budget for diabetes related expenditure in the world, and hence reversing diabetes or managing diabetes by nutrition becomes a very important task, because it does not ask for use of OHAs or use of insulin. Okay, so our bitter truth is we have uncontrolled diabetes. So now, but 70% of diabetics have uncontrolled diabetics. The mean HbA1c of India is 9%, and what is recommended is 7% or below. So therefore, it is at least 2% higher than that suggested by international bodies. Prevalence rate of diabetes is increasing rapidly, with an urban-rural divide of up to 2:1 to 3:1 maintained towards past 2 decades. So really, we always thought that people in cities have more diabetes, the people in smaller towns or villages have less diabetes. The reason is they are more physically active, but that is something which has not been seen, and we are seeing that there is diabetes both in urban and in rural area. Now, this is a very, very interesting study. This is coming from ICMR INDAP data, and ICMR INDAP is the ICMR's India Diabetes Study, and you will see that as the states become more and more rich, and here I would like to allude to Chandigarh because I'm speaking virtually in Chandigarh. So if you see, Chandigarh is a pretty rich union territory, and the prevalence of diabetes newly diagnosed is much higher as compared to Jharkhand, which is a poorer state. So prevalence of pre-diabetes again is much higher in Chandigarh, both in males and in females. And the significant risk factors for pre-diabetes were age, family history of diabetes, abdominal obesity, hypertension, and income status. So therefore, we are finding that the burden of diabetes is growing. Now let's come to our topic. So what do we know about diabetes? What we know is type 2 diabetes is an inevitably lifelong with irreversibility and progressive beta cell damage. So what we are taught in our school colleges is that once you get type 2 diabetes, it is a lifelong condition, it is irreversible, and there is a progressive beta cell damage. However, what was seen, the restoration of normal glucose metabolism within the days after bariatric surgery in majority of people with type 2 diabetes actually disproves this concept. So if it is inevitably lifelong condition, even bariatric surgery should not reverse it. But like Sunita ji said right in the beginning, that a lot of people, when they go into bariatric surgery, you find that as soon as they are post bariatric surgery, they are put off their OHAs, and even if a small amount of OHA is given, these people land up in hypoglycemia. So what was seen was this reversal of diabetes depends upon sudden and profound decrease in food intake, and it actually does not relate it to any direct surgical effects, and this was what was seen. Then there was a counterpoint study done to demonstrate that normal blood glucose levels and normal beta cell function could be restored by very, very low calorie diet alone. So what was counterpoint study? Counterpoint study was done by Roy Taylor from Newcastle. The hypothesis was tested that both beta cell failure and insulin resistance can be reversed by dietary restriction of energy intake alone. So what did Dr. Taylor do? He took 11 people with type 2 diabetes, average age of about 49 and a half years, average BMI, which was pretty high, of about 34, which had 9 males and 2 females. They were studied after 1 week, 4 weeks, and 8 weeks of a 600 kilocalorie diet per day. What they found is what they were trying to study is basal hepatic glucose output, hepatic and peripheral insulin sensitivity, beta cell functions were measured, pancreas and liver triglyceride content was measured using Dexon magnetic resonance imaging. That is, they did an MRI to measure it. Now, what was it that they concluded? So what did they do? They actually randomized these people to only a 600 calorie diet. They did not take a recall before they put these people on this diet. Whatever was the diet they were eating, they were directly brought to 600 kilocalories per day. And what did they find? Normalization of both beta cell function and hepatic sensitivity in type 2 diabetes was achieved by dietary energy restriction alone. This was associated with decrease in pancreatic and liver triglycerides. The abnormalities underlying type 2 diabetes are reversible by reduced dietary energy intake, and that is what they showed. And hence, there was an article which was given in Diabetic Medicine, and Dr. Roy Taylor was awarded something called as a Banting Memorial Lecture. So 14th November is Dr. Banting's birthday, which is celebrated as World Diabetes Day. Banting Memorial Lecture in American Diabetes Association meeting is one of the most prestigious orations that you can achieve. And you will see that Dr. Roy Taylor from the University of Newcastle upon Tyne, he was awarded this for this counterpoint study, and therefore he named his talk as Reversing the Twin Cycles of Type 2 Diabetes. So what did he say? He said that now it is clear that type 2 diabetes is a reversible condition So unlike what we have been studying for so many years, Dr. Roy Taylor actually said something exactly opposite. He said type 2 diabetes is a reversible condition. And what is this condition of? Intra-organ fat excess, to which some people are more susceptible than others. So what is the twin cycle hypothesis? Accumulation of fat in the liver. So we'll see that most of the time when we get patients of type 2 diabetes and you actually do their sonography, most of them have grade 1 or grade 2 fatty liver. So the accumulation of fat in the liver and therefore secondary even in the pancreas will lead to self-reinforcing cycle which interact with each other to bring about type 2 diabetes. So they are trying to tell us, Dr. Taylor is trying to tell us that actually fat accumulation in the liver and in the pancreas is the real reason why type 2 diabetes happens. And therefore he proposed this hypothesis called as the twin cycle hypothesis. So it's actual cycle. There are two wheels. Okay, this cycle is channelized or is given direction by caloric excess and insulin resistance. So like the handle of the cycle, wherever you take, if you turn the handle towards right, cycle turns right. If you turn it towards left, cycle turns left. So actually handle dictates which way cycle is going. Similarly, in real life, caloric excess and insulin resistance dictate where this cycle is going to go. And the driver of the cycle, okay, the pedal of the cycle is glucose. So what happens in this? Caloric excess and insulin resistance, when it is put into the system, increases the liver fat. Because there is an increase in liver fat, there is resistance in insulin suppression to hepatic glucose production. And therefore, there is increased basal secretion of insulin. High liver fat also causes increased VLDL, very low density triglycerides, into the bloodstream, which go into the pancreas and increase the islet cell triglycerides. So islet cells are beta cells in the pancreas. Therefore, there is a decreased response to the food. So there is a decreased response of the insulin to the food, which leads to hyperglycemia. And all this is being driven by glucose. So this is the same cycle which is shown in more diagrammatic way. So the bicycle is controlled by handlebars representing chronic excess caloric intake in presence of muscle insulin resistance. Rapid rise in insulin levels will expedite chronic excess calorie storage from carbohydrate via de novo lipogenesis and hence promote fat storage. This will cause the liver to become relatively resistant to insulin and a small increase in plasma glucose will occur. This in turn, insulin secretion will increase to control plasma glucose down. The further increase in insulin levels will bring about self-reinforcing cycles. Excess fat will result in increased exports of VLDL triglycerides from liver and its uptake by islet cells and inhibition of mealtime insulin secretion. At a personal threshold, the pancreatic fat becomes too much or too great a load and plasma glucose level will then rise relatively rapidly. Hepatic glucose production will increase. So therefore, if a person adjusts the handlebars and removes the driving factor, that is the positive caloric balance, these cycles can be removed. So now what is diabetes remission? Achieving a blood glucose below the diabetic range in absence of any active pharmacology or surgical therapy is called as diabetes remission. Diabetes remission by itself is divided into two parts. There is a complete remission and there is a partial remission. If complete remission lasts for more than 5 years, it would be considered as prolonged remission. Partial, complete, or prolonged remission was found to be 1.47, 0.14, and 0.007. So you'll see as you go ahead in the time frame. Partial remission is only for about 6 months to 1 year. But as you go ahead in the time frame, people are unable to manage caloric restriction and hence prolonged remission happens in 0.007 percent of people. And why do you think that happens? That happens because we are surrounded by food. All we think about is food. It is not only during Diwali time that we think about food. Just 15 days before Diwali, there is the Shera. Then just before the Shera, 9 days, there is Navratri. Then before that, there is Sawan. So at least in India, food intake really does not stop. So these are criteria for remission of diabetes, which is given by various groups, whether it is ADA, whether it is other groups. And what they are talking about is it has to be maintained for a year. HbA1c of 6.5 has to be maintained over for a year. Complete remission, that is no longer having pre-diabetes, is HbA1c of less than 6%, which is maintained over for a year. So either we are looking at a HbA1c between 6 and 6.5 to be called as partial remission or complete remission of type 2 diabetes. So what do guidelines suggest? Remission is defined as achieving a glycemia below the diabetic range in absence of active pharmacological or surgical therapy. It defines for the following three mutually exclusive states of remission. Just give me one second. Partial remission, which is subdiabetic hyperglycemia for at least 1 year between 5.7 to 6.4. Complete remission is when it's below 5.7, and prolonged remission, or like they would put a term called as cure or complete remission, that lasts for about 5 years. Now, Sunita ji was also alluding to this study, which is called as the direct trial. Okay, so this is primary care led weight management for remission of type 2 diabetes. It's an open label cluster randomized trial which is happening today also as we speak. The main author of this trial, or the main PI or the primary investigator of this trial, is again Dr. Roy Taylor. But this trial is taking place across United Kingdom, and it is led by, unfortunately, not by dietitians, but primary care, that is the GPs of those countries. So what are they doing? They are actually putting people. So what are they doing? Let me tell you. What is direct trial? Type 2 management focuses on pharmacological treatment. What has been shown is caloric restriction is beneficial for type 2 diabetes patients, but it is not routinely tested in primary care. So the study objective was, the direct trial was designed to assess whether intensive weight management can produce sustained remission in type 2 diabetes in a primary healthcare setting. So what was the aim? It was conducted to assess whether intensive weight management or weight loss in primary care would actually cause remission of type 2 diabetes. Finding from this open label cluster randomized trial shows that at 12 months, almost half of the participants, and just because it's 1 year study, it was found that almost half of the participants achieved remission to a non-diabetic state and were completely off anti-diabetic medication. Remission of type 2 diabetes is a practical target in primary healthcare practice. So what was the study inclusion criteria? It took people all between ages of 20 and 65 and a BMI of 27 to 45. Now remember, this study was done in UK, and therefore their BMI obesity cutoffs are at 25. What was the end point at 12 months? Greater than equal to 15 kilos of weight loss. Diabetic remission was defined as HbA1c less than equal to 6.5% after 2 months without any diabetes medication. So this was how they were taken. There was a population of 298 in which 149 were control and 149 were intensive treatment group. These were given best care guidelines up to 52 weeks. These were stopped on their anti-diabetic and anti-hypertensive medication. They were given a total diet replacement. They were given meal replacement for first 20 weeks. Then there was a food reintroduction for between 2 to 8 weeks. And then there was a weight loss maintenance phase for about 52 weeks. And what did they find? They found that people, about 46% could achieve remission in the intervention group, and about 24% of them achieved a weight loss greater equal to 15 kilograms at the end of 12 months. And what did they show? As the weight loss increases, the rates of remission increase. So people who lost less than 5 kilos of weight, only 7% achieved remission. People who lost 5 to 10 kgs of weight, about 34% achieved remission. People who lost between 10 and 15 kilos of weight, 57% achieved remission. But when in the group where people lost greater than 15 kilograms of weight, 86% of the people actually achieved remission at the end of 12 months. So what was a co-primary outcome? Okay, so co-primary outcome was a weight loss of 15 kilos or more and remission of diabetes, which was referred to as glycated HB hemoglobin less than 6.5% for at least 2 months of all anti-diabetic medications from the baseline at 12 months. Only problem is there was a lot of iteration when there was the acute phase and later on as well. So they could not, there was a group of people who could not complete this. The blue one is the group of people who could not go on such a heavy restrictive caloric restriction. So in intervention group, about so proportion achieving greater than 15 kilograms weight loss was about 24%. Okay, in the intervention, the proportion achieving remission at 12 months was about 46%, and this was shown with a confidence with a statistical significance with p less than 0.0001%. So this is the same thing again. It is shown that as the weight loss increases, the number of amount of people having remission increases. Now, 2-year evidence of direct trial was released on 6th March 2019 last year. This year, I think because of COVID, they actually did not release the data, but the trial is still on. It reported clinical outcomes in the intervention and control group at 2 years in order to assess the durability of intervention effect identified at 1 year time point. Now, what did they find? After 2 years, this 24% became actually 11% because people could not follow the strict diet control that it demanded. So at 24 months, weight loss of 15 kg or more from the baseline was recorded in 17 patients. That is only 11.4% of people of 149 participants in the intervention group. So what happened is even people who had lost weight started regaining because they started eating. So here it was 45.6%. Now it has become, at the end of 2 years, it has become 35.6, and probably at the end of 3 years, it may be even more. So what from the earlier study population for whom 24 months data were available, remission at 24 months was also achieved by 5% of participants who lost less than 5 kgs, 29% of participants who maintained 5 kgs to 10 kgs, 60% of participants who maintained 10 kgs to 15 kgs, and 64% of participants who maintained at least 10 kgs of weight loss, and 70% of participants in who had lost more than 15 kgs. So what is the crux, friend? The crux is if you keep on losing weight, and it is not about weight loss, it is if you keep maintaining the lost weight, diabetes remission will continue. So that is what they have shown in 2 years analysis also, and this study is likely to go on for 6 years. Now, what are the benefits of remission of diabetes? I don't think I need to read this slide, but I need to tell you. Removes personal and social stigma of disease or diabetes. It provides a target and a reward for sustained hard work. So typically, when our patients don't see anything big happening other than weight loss, they really do not feel like to maintain the weight loss, but here you get a reward for it, that you are off all the medications for diabetes. May permit life insurance, mortgage, travel insurance without high premiums, especially in country like India, where your insurance, you do not get insurance once you report a high blood glucose, and remove some occupational hazard, especially in certain occupations like maybe the military or the any of the services, maybe in certain other occupations like if they want to become a pilot or something else where these things are very, very important. For epidemiology and healthcare system, identifies a valuable indicator for success in healthcare through national disease register monitoring. It allows for better analysis for long-term morbidity and mortality risk, and it improves resource requirement in forecasting. This was one study. There was also another study, which was Look Ahead trial, where an intensive lifestyle intervention was associated with greater likelihood for partial remission of type 2 diabetes compared with just a diabetes support and education group. And here also we found that if there was complete or partial remission only when there was a lot of intensive lifestyle management, which was accompanied by a lot of caloric restriction using meal replacement. Then in India, Dr. Unnikrishnan from Pune tried to do the same thing, and he published the data in Indian Journal of Endocrinology and Metabolism, where he has shown, along with Dr. Anjali Bhatt, who is a very, very dear friend, that in long-term follow-up proves that sustained benefits such as dietary restriction may be an alternative to more drastic option for reversal of type 2 diabetes. And again, this paper was also published in Indian Journal of Endocrinology and Metabolism. So what are the questions to be answered? Is long-standing type 2 diabetes reversible? Counterpoint studies involve only people with short duration of diabetes. So therefore, we really do not know about that. But Stephen S. and Cohen R. suggested that many people reverse long duration of type 2 diabetes. One person actually reversed it after 28 years of diabetes after following a hypocaloric diet, and hence right now we do not have a definitive answer if somebody as old as 28 years. One case we have, but we do not know of many people. Is diabetes with normal BMI reversible? Yes. If a person of normal BMI is with classical type 2 diabetes, or if that person of normal BMI has an ethnicity of Southeast Asia. So we are all Southeast Asian ethnicity, and in our ethnicity, even with normal BMI, if you put them on a very, very low calorie diet, this diabetes reversible, because this question is asked to us lot of times when we do not actually have people with a BMI of 29 or 30 whose diabetes we want to reverse. We have people with a BMI of 24, 25, or even sometimes at BMI of 23, whether we can reverse their diabetes. And yes, it has been shown that if you have Southeast Asian ethnicity, this diabetes can be reversed. Will diabetes come back? Well, it won't, provided that the weight is kept down below an individual's personal fat threshold to trigger type 2 diabetes. Now, you saw that in the study, there are variable limits. Somebody could reverse diabetes even at a 5% loss of body weight, and somebody could not even reverse at 15% body weight. And therefore, each one has its own threshold of fat, and that has to be respected, and that has to be individualized when you formulate a program for reversal of diabetes. What is the best advice to prevent weight gain? Certainly, it must be a eucaloric diet, which is about 600 to 800 kilocalories, with a daily increase in physical activity. And this is what a low-calorie vegetarian, this is something that I use in my practice, and hence I've shown you this is a very, very low-calorie vegetarian diet with chila, with paneer and salad and one roti, nuts, and a dinner of one roti and hummus. This is just one plan. There are many such plans. This is a 600 calorie, very low calorie, non-vegetarian diet. Now, I wanted to show you one case study. Okay, I have many such patients with reversal, but I wanted to show you one case study of a 53-year-old obese postmenopausal woman. Okay, she visited me in 2018, and this is a slide made in 2019. So this lady actually is a 53-year-old lady in 2019. So then she was 50-year-old in 2017. She went to UK to meet her daughter. Okay, and she went there, and naturally she went to UK. बेटी के घर गई थी, तो बेटी ने खूब खातिरदारी की. And when she came back to India, she just did her sugars, and she found that her fasting plasma glucose was 333, her postprandial plasma glucose was 516, and her HbA1c was 10.8. After which she went to the doctor, and eventually she was kept on multiple medications, and her blood sugars came down to fasting 59 and a postprandial of 105 in about couple of months. Okay, so in about a month. Okay, and then she kept on being maintained on that blood glucose with those medications, but she started to find that eventually her blood glucose, despite of medications, started increasing. And then there came a point when her blood sugar with medication was 120 fasting, 205 postprandial, and that's when her yoga teacher actually referred her to me. Okay, that time her HbA1c was 7.1, and this is the point where we did dietary intervention. Till then, she was not doing dietary intervention. So during her first visit, patient was on following medication. So at this point, at 2/8/2018, patient was taking metformin 500 milligrams twice a day, dapagliflozin, that is SGLT2 inhibitors, 10 milligrams once a day, vitamin supplement, and medication for hypertension, that is ARB. She was taking an angiotensin receptor blocker once a day. Patient was advised to follow a diet, and after 1 year, so she was also put on a very low calorie diet. And after 1 year, patient was on following medication, metformin 500 milligrams once a day in March of 2018, and for hypertension, calcium channel blocker and angiotensin receptor blocker. During our last visit in 2019, patient has just lost 5.5 kg of weight over 4 months. So if you see, she hadn't lost 15 kilos of weight. She just lost 5.5 kilograms of weight over 4 months, but her sugars are completely normal. Currently, patient is not consuming any medications for diabetes and is simply following prescribed diet plan. In fact, the patient does not like to exercise, and all she does is a little bit of exercise, yoga twice a week, and that yoga teacher is one who sent her to me. Now, this is her diet recall. Okay, she is a Sindhi patient. Okay, so her morning she began before coming to me. So this was her recall. She began her morning with cup of tea without sugar, with either two biscuits, which are typically Mari biscuit, or rusk, that is suji ka toast. Okay. For breakfast, she used to have 2 to 3 idlis or homemade 2 dosas with sambar, or she would have one and a half bowl of poha or upma. She would have egg once in a week with 2 brown bread slices. For lunch, she would have a bowl of sabzi or dal, never both, either or, with 2 to 3 fulkas, wheat flour ka fulka, and some salad. Snack, she would have tea without sugar with either 4 biscuits or sukha bel. Sukha bel is kurmura with save and a little bit of pyaz tomato on it, or she would have khakra. And in dinner, she would have something which is Sindhi preparation. So she would have either Sindhi kadhi, or she would have dal, or she would have pulses like chana, etc. One bowl with 2 bowls of rice, or on couple of days when she would eat non-veg, she would have chicken preparation once or 2 times a week, and or with 2 to 3 fulkas. This is her dietary call. Now, my dear friends, I can't see you, and that is something I hate about webinars, because we cannot ever see what audience thinks. But believe me, this is what 99% of this country consumes. If you see, this is not really a bad diet. Now, what did we do? We gave her in the morning a glass of water with chia seeds, cinnamon, and almonds. Her breakfast was a cup of tea without sugar, a omelette, that is 1 whole egg and 2 egg whites with vegetables, or a chila with moong dal or a chana dal and curd. We did not give her either bread or roti, definitely no poha, upma, and South Indian food. Then for lunch, we gave her a bowl of dal with sprouts, a bowl of sabzi which did not have aloo in it, a bowl of veg raita, and 2 fulkas with besan and wheat flour mixed in proportion of 1:1. In the evening, gave her a fruit and a mixed nut, 15 in number, with almond, walnuts, and pistachios. And in dinner, we gave her a Sindhi curry or sai bhaji, or a chicken preparation with 1 fulka with besan and wheat flour in proportion of 1:1. Out of all this was a meal plan for her. We told her that one of any meal could be replaced by meal replacement as per her choice. The salient features of intervention were: pathophysiology of type 2 diabetes was explained in detail. We took a robust diet recall, 3 days and 3 working days, and uh, 2 working days and 1 holiday, and a 7-day. Both kind of recalls were taken. Diet plan was very, very similar to what was eaten at her home. We actually called her cook for the dietary counseling. No special meals or cooking methods were recommended. Portion control with her home utensils was taught. Importance of order of eating, and I am a very big believer of order of eating. So I always teach patients to eat, start with a protein and end with a carb. So she could never manage these two full carbs. She barely ate half of the full carb that was given to her. Importance of order of eating was explained, and she could eat out and use a meal replacer for one of the meals on that day. Okay. What was the patient's response? Diet regime was really strictly followed by her. Due to order of eating, she was unable to eat carbohydrate rich cereals like roti or rice most of the time. So she rarely ate a roti or rice. She was able to eat out once a week with her family and attend 3 kitty parties a month. Okay, so she has a very, very busy social life. She was looking leaner and fitter and hence was receiving more compliments. She was happiest when she was put off all OHAs and she could still maintain a blood glucose. And it is 2020 November. Even now, she's off all OHAs. She monitors her blood glucose regularly. She didn't monitor when her blood glucoses were high. But now, because they come normal, she monitors them very, very regularly. It boosted her self confidence and she was able to change her eating patterns and that of everybody at her home. So, everybody started to eat like her. And because of her robust eating pattern, the net weight loss in the family of five was 30 kilograms. And her husband shifted from being pre diabetic to being normal blood glucose. So, this is reversal of diabetes for you, my dear friends. Thank you so much for a patient hearing. Do you want me to start immediately the carb counting or you want to take questions here? Hello? 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 Should I start carb counting?
Ma'am, I think you can start with carbohydrate counting, and then in the end, we can take all the questions.
Yeah, there is a lag, I guess, so you can't hear me.
A little bit, ma'am.
Okay, no problem. I'll start carb. Can you see the slides? Can you see the slides?
Yes, ma'am.
So I'll begin with carbohydrate counting. So carbohydrate counting, like Sunita ma'am said, that it is a meal planning approach which is globally acceptable nowadays, and therefore there is a lot of talk about it. So what is carbohydrate counting? Carbohydrate counting is a meal planning approach used for diabetics, which focuses on carbohydrate as a primary nutrient affecting postprandial glycemic response. See, remember, when we plan diets, there are so many things to take care that it is sometimes difficult for us to tell this to patients. Carb counting is typically used in type 1 diabetes. Carb counting in terms of managing the amount of carbohydrates can be used in type 2 diabetes and can be used in GDM, but classical carb counting, where it opens out your eating approach, cannot be given to type 2 diabetes and to GDM. So, what is the history of carb counting? Carb counting was used in Europe in 1921, and it was one of the most successful approaches used in DCCT trial. DCCT is a type 1 diabetes, largest type 1 diabetes trial, which is called as Diabetes Control and Complications Trial. It was conducted and it was used. During that trial, this was the approach used. And therefore, there has been renewed interest since then in this technique. Now, why use carb counting? Now, my dear friends, 14 November is World Diabetes Day, but in India, we also celebrate it as Children's Day. And you will realize that type 1 diabetes, which is usually detected in a younger age, lot of times our patients are kids. Yeah, they are children. And remember, on Children's Day, the gift that we can give children is of normal eating. I am not saying eating junk. I'm just saying eating normal, like any other child in this world. जिस दिन मिठाई खाने का मन हुआ, उस दिन मिठाई खाई, रोज नहीं खाई. So like any other child would ask his mother, his or her mother that I want a piece of chocolate or I want a piece of whatever mithai one of the days in the week, and the mother never thinks twice before giving it, then why not give the same rights to the patients, young patients, our young patients of type 1 diabetes? And therefore, this is our approach where we liberalize the eating. So, diabetes control requires constant attention to diet. Remember, if a person gets type 1 diabetes at the age of 5 or 6 or 7, remember they are carrying diabetes with them to school, they are carrying diabetes with them to the holiday, they are carrying diabetes with them in puberty, they are carrying diabetes with them when they have their first girlfriends and boyfriends, they are carrying their diabetes with them in their marriage, on their honeymoon, so on and so forth. So remember, there is no chutti from diabetes. What is seen as strict and structured regimes are associated with decreased compliance. And this is a whole audience of dietitians where you will hear people saying that, madam, जब तक आपको नहीं मिले थे ना, हमको चीनी खाने का मन भी नहीं होता था. पर अब आपने नहीं बोला है ना, तब से हर जगह मिठाई वाले की दुकान दिखती है. Okay, so this is a very, very big problem. More strict you become, more you want to break it. Okay, so simple dietary guidelines and recommendations can result in improvement in patient understanding of diabetes and therefore compliance. Now, what is the principle of carb counting? Principle of carb counting is carb is a carb is a carb. So it's very simple. Carbohydrate gets converted to glucose faster than fats and protein, and amount of carbohydrates in the food should be given first priority as compared to type. And it has been shown that long-term outcomes, that is glycosylated hemoglobin and fructosamine, are more dependent on amount of carbohydrate rather than type of carbohydrate, that is glycemic index of the food. And hence, we calculate all carbs at the base level or at the same level. Carbohydrate is a main factor affecting postprandial blood glucose excursion and thus even the insulin requirement. So insulin requirement is actually decided by the number of carbs that you eat. And I'm sure this question comes to everybody, that all our patients go home with a written regime from a doctor, say 4 units or 5 units of insulin in one meal. And you realize that when they eat a aloo paratha, because it's in Chandigarh, I can give you Punjabi examples of food. So maybe aloo paratha or maybe aloo ki sabzi or puri, ya anything which is high carb, aloo ki tikki, you find that that dose is never enough. Then does that mean that that person, if that 6-year-old kid gets diabetes, okay, at the age of 6, and if the average life expectancy in India is 68 years, then for next 61 years, you are expecting that person never to touch aloo paratha, never to touch aloo ki tikki, never to eat aloo and puri? I think that's a very, very tall order. Okay, we as dietitians also, when I come to Ludhiana, I definitely have a aloo paratha, I definitely have aloo tikki, and I definitely have butter chicken. So after being in this profession for so long, if I feel like breaking it, I'm very sure a 6-year-old child will feel like breaking the rule. So therefore, what does it do is it actually helps you just to count one nutrient. So carbohydrate is converted to glucose within first 2 hours of eating. So therefore, what is the advantage? It places emphasis only on carbohydrate, the nutrient that has greatest impact on blood glucose. Counting in grams or portion can be made into a very familiar concept. Carb counting offers patient a wide variety of food choices without enforcing any specific food group. So, I hear this a lot of times from the mothers of children who have type 1 diabetes कि मैं उसको चाहती तो बहुत हूँ कि वो करेले की सब्जी खाए, चाहती तो बहुत हूँ कि वो मेथी की सब्जी खाए. Why would a 6-year-old eat karele ki sabzi? I have nothing against it. If the 6-year-old likes karele ki sabzi, but just because that child has type 1 diabetes does not mean that his life has become karele ki sabzi. That's what I'm trying to tell you. It makes easier for patient to achieve a tighter blood glucose control, as this method provides accuracy while calculating the amount of carbohydrate in the food, and sound nutritional recommendations can be incorporated. So how do you get started with carb count? You start with basic food and meal planning guidelines. Where are the carbohydrate containing foods? That is cereal, pulses, fruit, milk, and desserts. See, what people know is cereal and desserts. They have no clue that other things also have carbohydrate. We talk about consistency in timing, type, amount of carbohydrate. We definitely speak about portion sizes, and because carbohydrate counting tends to control sugars very tightly, we always speak about symptom and treatment of hypoglycemia. So, what are the tools for carbohydrate counting? They are measuring cups and spoons, food weighing scales, nutritive value books, and carb counting books. And we run the patient over first level, second level, and third level of carb counting gradually, not together. Now, who are the people who are good for carbohydrate counting? First of all, people who desire less structured method of choosing food. See, there are a set of people who will eat palak ki sabzi and roti every afternoon if you tell them. They are not the people who require carb counting. These are people who desire less structured method of choosing food. Patient learns why consistent carbohydrate intake is important in relation to blood glucose level. Patient also learns about the foods that contain carbohydrate, the concept of carbohydrate choices, and how to count carbohydrate. Patients are taught to keep food records and identify portion size. The target range of blood glucose can be negotiated with the patient depending upon what patient eats. Now, if you look up Google, you will find this 15 grams of carbohydrate is equal to one carb serving. Now, I know it is technically 15 grams of carb, but I get these small children for counseling, and I have understood one thing: 15 ka table is very difficult to memorize. And therefore, in my practice, I have made 10 gram of carbohydrate is one carb exchange, because 10 ka table is very, very easy. If you know table of 1, you definitely know table of 10. So therefore, all these foods have 10 gram of carbohydrate in them. I've done it on palm to standardize it. This is my palm. So we are using standard woman's palm. These are raw foods and these are their cooked counterparts, all containing 10 grams of carbohydrate. Pardon me, most of the foods here are foods eaten in Mumbai. So most of them are Marathi foods. You will really find very few Punjabi options here or North Indian options here, but you will have to make do with it. Okay. So these all contain 10 grams of carbohydrate. Okay. Look at pasta. About 12 strands of pasta is 10 grams of carbohydrate. And if you see, kids eat this by kilograms and expect the sugars to be completely normal. Look at the other things. Vermicelli. Vari is kodo millet. Okay. This is thepla. This is a Gujarati food. This is aloo paratha from Maharashtra. So small. So it's really not like the aloo paratha which looks in Chandigarh or in Ludhiana. And these are doklas. This is puri. These are various pulses, and you'll find that you can eat much more. These are moth, moong, chana dal, lobia, and green peas. And these are after sprouting and cooking them. Okay, these are soy chunks, and these are various vegetables which are chopped, and asterisk 2 means into 2. Okay, and why I have written this is because you don't need to calculate them. That 2 times bhindi is made for family of 2. Nobody is eating that much bhindi alone. Or that much of bitter gourd 2 times is made for, I think, family of 4. So remember, you do not need to calculate vegetables. And for that precise reason, 4 times this of cabbage is eaten by no single person. Okay, but what is very important is this. Okay, so 13 fries makes 10 grams of carb, 9 potato wedges, yeah, 7 pakoras of aloo make 10 grams of carbs, or a handful of potato cubes makes up 10 grams of carbs. These are various fruits again, and these are nuts. Now look at these nuts. Does that mean I have to eat 108 almonds? No. It means that if you eat 5 or 6 almonds, you do not need to give insulin to that patient. If you eat 2 or 3 walnuts, you do not need to give a short-acting insulin for that patient to control his or her blood glucose. Or if you give 1 slice of cheese, you really do not need to give insulin for the same. Or 2 or 3 pieces of paneer, you do not need insulin for the same. But look at sugar and look at jaggery. Very little. Okay, these are various cookies or biscuits which are available in the market. And if you see, there is little difference between them. See, 5 Maris or 3 Parle G or is giving that much amount of carbohydrate, even hide and seek. Okay, so this, what does this do? This gives a patient a chance to eat all. Am I recommending a person with diabetes to eat Pure Magic or Bourbon or Jim Jam? I'm not recommending. But imagine a 6-year-old child is never going to eat pure magic biscuit ever in his life because he or she has diabetes. I think it's a very tall order, like I said before. These are various drinks. Okay. These are various cakes. These are cakes from Monginis. I think Monginis is a chain in Mumbai. So this is the only labeled chain. So therefore, these are flakes. And look at special K. It's no different from the other cornflakes. In fact, they are lesser. So you can eat lesser special K because they have more carbohydrate as compared to others. And look at Bonvita. This is like the national health drink. And that is why I have kept it here. These are noodles. This is national snack. Most of the kids come home and eat all this. So, and these are snacks. 20 banana chips or 14 smart chips, so on and so forth. Kurkure, one small packet. Okay, these are all snacks which are eaten in Maharashtra. These are very popular during Diwali time. All of these. These are some typical Maharashtrian snacks, thalipeeth, sabudana vada, aru vadi. These are eaten very, very often by kids here. And these are various sizes of breads. And these are some of the sweets which are labeled. A small gulab jamun, half a kala jamun. Shira is the suji ka halwa. It's called shira there. And these are Rajgira amaranth laddus which are eaten in during fast. So these are a couple of things which I have labeled. Look at Shrikand. Shrikand is again a very, very popular sweet which is eaten in Maharashtra. Just a thumbful of it can be eaten for 10 grams of carbohydrate. And these are various chocolates which can be eaten as 10 grams of carbohydrate, and even the McDonald's. Yeah, because most of the birthday parties are held in McDonald's, and therefore you need to know what is the carb content of their foods. Okay, even KFC is here. Oh, sorry, Domino's. Sorry. So what patients are taught? Patients are taught to identify food groups, to count food in terms of grams, convert the weighed food into proportions like cup, vati is the bowl or spoons, translate the number of grams of carb negotiated for each meal into a specific food suggestion, and assist the patient in planning sample menus with the correct carb content. Patients are suggested resource where they can find carbohydrate, fat, and protein contents of the food. We need to explain the patient relationship between carb consumption and insulin requirement. Lot of times when mothers give children snack to eat in the evening, say they give a fruit, they give a banana, they do not bother to give insulin. And then they wonder why is the HbA1c coming high. They always think that because fruit comes from a natural source, if you don't give insulin, that's fine. And a lot of times it is not. Explain how to use information on packages and label. And these are all examples of one carb serving. This is a 60-gram carbohydrate, 4 servings of carbs, and these are various meal options. Then from level 1, we take patient to level 2. For patients who have mastered level 1, patient continue to master record keeping skills, and your patient starts dealing with more complex food, such as restaurant meals. Patient also learns the effect of fiber, protein, and fat, learns to identify pattern of blood glucose levels which are related to food. At this point, we start teaching patients to adjust insulin and adjust insulin for physical activity. What are pattern management skills? So we teach patients to study record books and look out for blood glucose levels that are outside the target range. We find and interpret blood glucose pattern, notifying frequency and circumstances which are related to pattern. And then dietitian and patients decide together which item of diabetes management regime requires adjustment, insulin regime or carb intake. I'll give you an example. Like I told you, if patient wants to snack at about 4 o'clock in the evening and patient is eating a considerable amount of carbohydrate, whether in form of fruit or a healthier snack, but patient refuses to take insulin, then your insulin regime requires correction. Means you have to add insulin. But if patient says that I will not add insulin, then the carb intake requires correction. That is, you do not give a snack which is carb, whether even if it is a fruit, and you give nuts or you give a slice of cheese or you give a boiled egg, but you do not give a carb. So depending upon the pattern and what is required, we need to change a regime of either insulin or carb intake. Weight gain. Now, the biggest side effect of carb counting is weight gain. Why? Because it is liberalizing eating. You are never saying no to anything that patient eats, and therefore there is weight gain. So, what are the reasons of weight gain? There is a lack of attention to protein and fats because we are busy calculating carbs. And in India, protein is not a problem because nobody is eating that many protein. But what is a problem is the fat because roti requires insulin and puri requires the same amount of insulin. So, a lot of times kids prefer to eat a puri instead, and therefore the weight gain happens. Sometimes over-treating hypoglycemia or predicting a hypoglycemia before it has happened and treating it. Sometimes when the patient's sugar is 80, they actually treat themselves for hypoglycemia so that it does not go down. Will lead to weight gain because in hypoglycemia, you tend to consume a lot of carbohydrate. And remember one thing, improved glycemic control. When your sugar is better, there is automatically some amount of weight gain. Once this is done, we take patient to advanced carb counting. This is meant for patients who are on intensive insulin therapy, that is MDI, multiple daily insulin doses, or insulin pump, that is CSII. Here we teach patients insulin to carbohydrate ratio, and remember, patient may have more than one ratio through the day. And we also teach patients to calculate insulin sensitivity factor. So what are the skills which are required? They require understanding of target glucose levels and when to take action. Like I said, they cannot take action at a blood glucose of 80 thinking that a hypoglycemia is going to hit. You need to educate these patients much better. They understand all aspects of basic carb counting, and most importantly is record keeping. If they cannot keep record, they cannot do SMBG, they really cannot do carb counting. They need to understand insulin actions. What are the different actions of insulin? What is a basal? What is a bolus? Which are different types of boluses? Which are different types of basal? They need to understand it very well. They need to understand to read patterns, which was a part of level 2, and they need to understand the importance of record management. Other than that, what they required is they require basic math skill. So they require to calculate bolus doses using insulin to carb ratio. So they need to know multiplication, division, addition, subtraction. Calculate insulin sensitivity factor in correction or supplemental dose of insulin. And they need to understand to learn to make adjustment for special situation. Now, how do you determine their bolus dose? We determine by using the rule of 450 or using the rule of 500. So you take the rule of 450 or 500, whichever works for you. Here I've taken 500. You divide the total daily dose. And what is the total daily dose? Total daily dose is addition of long-acting and short-acting insulin both. So say patient had had a total daily dose of 34, then 500 divided by 34 gives you 15. So therefore, for 1 unit of insulin, you require 15 grams of carbohydrate as a dose. So look at this sample menu. A patient ate 2 exchanges of onion poha, which gave him 45 grams of carbs. Then he had 1 cup of cow milk, that is 5 grams of carb, and ate 1 fruit, that is orange, that is giving him 10 grams of carb. The net carbohydrate here is 60 gram, 45 plus 10 is 55, plus 5 is 60. 60 gram of carb divided by an insulin to carb ratio of 15. So 60 divided by 15, 4 units is the dose of insulin which patient requires. This is a South Indian menu. This is a North Indian menu for the same thing. So therefore, this is how insulin to carb ratio is used. Now, once you need to make insulin adjustment for larger or smaller snacks than usually planned, and divide total number of carbohydrates by the ratio. Now, what about the other nutrients? Fiber more than 5 gram per serving should be subtracted from total carbohydrates of the food. But to get this kind of fiber, patients need to eat a lot of vegetable or pulses, which our patients don't eat. So usually we never subtract it. Therefore, we do not calculate vegetables to begin with. So if somebody is eating French beans or somebody is eating cluster beans, we never calculate them as a carbohydrate at all. Large amount of protein in a meal can produce hyperglycemia 3 to 5 hours after the consumption of meal. So for example, patient has just tandoori chicken for me. Then it will not cause a 2-hour rise, but it will cause a 4-hour rise. And therefore, you have to give insulin to this patient much later in the cycle. Fat slow gastric emptying and may require adjustment in time or delay in addition of pre-meal insulin or short-acting insulin. So instead of roti, if the patient ate puri, then you might have to give insulin a little later rather than before the meal because gastric emptying is delayed. So this is the effect of protein again. Protein sometimes, so even if the patient eats say only tandoori chicken for a meal and does not eat a roti or a bread with it, even then patient will require some amount of insulin because if only protein is eaten, some amount of protein is converted to glucose by gluconeogenesis and like previously thought, and glucose from the protein being incorporated into hepatic glycogen store but not increasing the rate of hepatic glucose release. Now, supplemental or correction doses, you use insulin sensitivity factor, and there are two rules. There's a rule of 1500 if you use regular insulin, and there is a rule of 1800 if you use Lispro or aspart insulin. Again, you divide the total daily dose, that is the addition of short acting and long acting insulin, with a 1500 or 1800, depending upon which insulin is used. 1800 will be used if the insulin is Lispro or aspart. 1500 is if the insulin used is regular insulin. So say if the total daily dose is 60 units, then 1800 by 60 is 30. That means 1 unit of the short acting insulin drops blood glucose by 30 milligrams per deciliter, and this factor is known as insulin sensitivity factor. This is used widely to correct high blood glucoses before the meals or in between. So remember, for snacking, individual situations must be considered, and remember there's a huge potential for weight gain if the snacks are not planned into total calories. Now I started using this and I then realized that I learned this in the Jocelyn Clinic in the US. So when I came to India, I thought that I'll be able to use it very easily in all the patients. But when I started using it, these are the problems that I realized. All meals are rich in carbohydrates. So while in other countries, some meals have carbohydrates, typically breakfast have carbohydrate because they eat a cereal or something. Lunches and dinners are usually a piece of meat with a little bit of salad and sometimes a little bit of potato or a bread. In India, everything that the patient eats, breakfast, lunch, dinner, and snack, everything is a carbohydrate. The second problem is serving size is not consistent. A aloo paratha in Bombay is made with 30 grams of flour. In Punjab is made with 60 grams of flour. And everything is one aloo paratha. So the serving size is not consistent. Carbohydrate content of all the ready-to-eat food is not known. Even today, we have a huge cottage industry where food is made at home and is sold, and a lot of times it is not labeled. There's no food labeling, and SMBG means patients should measure their blood glucose at home pre and post every meal. Now, whoever here is dealing with type 1 diabetics will tell you that every time you're trying to monitor patients' blood glucose pre and post every meal, the first thing that mothers complain is, इतने बार टेस्ट करेंगे तो खून कम हो जाएगा. Okay, so that is a huge problem. What are the solutions to Indian problem? Detailed counseling. My carbohydrate counting plans go over 6 weeks, at least 1.5 months. Use of carbohydrate at patient's house to explain the concept and using the measures. Have person cooking at home during counseling. I do not know about Chandigarh, but in Mumbai there are houses in which lady of the house never enters the kitchen. It's always the cook who enters. So then have the cook during counseling. Okay. Calculate and note values of patient's favorite food in a booklet so that you will find that the patient repeatedly eats this food and starts getting success when you have noted the values. You insist on record keeping and please insist on self-monitoring of blood glucose. And if the patient is unable to do either record keeping or self-monitoring of blood glucose, please refuse carbohydrate counting in such patients. So in summary, know your pre-meal and post-meal targets and when to make adjustment. Use pattern management skill. Calculate bolus doses based on insulin to carb ratio and basal doses, and use of insulin sensitivity factor should be done. I showed you all these slides because I firmly believe that human beings, though know nutrition, do not eat them. They do not eat nutrients. They eat food, and hence conversion of nutrients into the food is going to go a long way, where it's going to tell us how to work with our patients. It's not getting stopped. Just give me 1 sec. Yeah.
That was a wonderful session, Mrs. Shilpa. Thoroughly enjoyed it. Wonderful.
Are they happy to take any questions if there are?
Yeah, sure. I think there are
Yeah.
lots. There are
Ma'am,
lots.
there are a lot of questions. So the first question that we got here was at what stage can diabetes actually be reversed? If you're talking
I'm
of
sorry, I
reversal
did
of
not
diabetes,
get the question.
the question is that at what stage diabetes can actually be reversed?
So, if I showed you my case, in which the patient was on 3 drugs. So when the patient began, patient was on 3 drugs, and then eventually on 2 drugs when patient came to me, and we could reverse. I've also seen patients with insulin, but not with other complications being reversed. So patient at any stage can be reversed, and even there are some studies showing that patients as old as with 28 years of diabetes have also been reversed. So I am sure patients at all stages can be reversed. The difficult part is calorie control.
That is true. And another very interesting question that we had was that coincidentally, World Diabetes Day also falls on the 14th of November, which is Diwali. So, any tips basically to control sugar levels during festivals?
Um, so easiest tip would be portion control. So if you're having mithai, have it on the day of
That's
Diwali, and you don't have to have it in breakfast, lunch, and dinner. You can choose whichever meal you think your pasand ki mithai is made. Eat there and stop it. I think what is very important in our country as a awareness is Diwali is also a festival of giving. So in Diwali, we try to give people mithai, as a celebration. I would urge at least the dietitians in this group, mithai mat dena ek dusre ko. Give nuts, give fruit. Please don't give mithai. And if you can't give either of them, don't give anything. Just give your best
Don't give
wishes.
it.
I think they are the lowest in calories and
that's
highest in effectivity. Yeah. So just don't give anything. You don't have to give something to show your love and affection.
and
By
especially
not
with I think the carbohydrate counting that ma'am has told.
Yeah.
Yeah.
So by not giving, you're showing your love and affection so that you're preventing them from getting diabetes.
So don't love anyone with food, they say.
Yes, yes. You can love them with many other things. There is
Many
whole
other things.
Amazon and other things there. You can shop for whatever you want. Don't
Exactly.
shop for food.
So I hope everyone's got that take-home message for Diwali. Diwali, not just the nutritionists, whoever is participating in this webinar, please pass this message. Let's take care and we don't fall into the trap of diabetes. And another question, ma'am, we have here is: do artificial sweeteners aggravate diabetes?
There is no data as such to show that if you're using a particular sweetener, it has aggravated diabetes. What aggravates diabetes is the net caloric content. So I'll tell you what is the problem. See, अगर जो आपने घर में गाजर का हलवा बनाया चीनी डाल के, तो जिस बंदे को डायबिटीज है वो आधा बोल खाएगा और खुद को 200 बार कोसेगा कि मैंने क्यों खाया. अब आपने स्वीटनर डाल के बनाया तो 200 बोल खाएगा और एक बार भी नहीं कोसेगा खुद को. Correct? And what will happen is the net calories from gajar ka halwa will increase. When the net calories increase, diabetes gets mismanaged. So remember, only sugar does not cause mismanagement of diabetes. Net calories causes. And गाजर के हलवे में cream है, खोया है, nuts है, गाजर है, घी है. That all causes diabetes. So sugar is only one part of it. So when the use of sweetener has to be as a tabletop sweetener. Chai, coffee. Don't use it to make burfis and mithais and whatever you are making.
Yeah.
मुझे तो अभी ये- Another question that we have is that
Ma'am was saying something.
No,
Sunita
I
ma'am
was
was
not.
saying.
Yeah, Shilpa, what's your take on sugar-free sweets, which everybody is promoting? All these, I mean, big sweet houses. So, what's your take?
My opinion, I may be very crude in the way I'm saying, but when I say कि पाप करना है ना तो पूरा पाप करो। ये half baked पाप में कोई मतलब नहीं है। इस पाप with yoga और पुण्य, there is no meaning. You want to eat a sweet, eat a little bit of regular
Little
sweet,
portion.
yeah, and understand that there are side effects rather than eating a lot of sugar-free sweet and still causing a higher HbA1c. फिर तो क्या खुशी
Yeah.
मिलती ना पेशेंट को कि मैडम मैंने तो बिना शुगर का खाया फिर भी बढ़ गई तो फिर खुशी
So that's
Shilpa
a
ma'am,
very big
how
thing.
do
That's a good message. Yes,
how do
please.
these meal replacers work? Are they really effective? The meal
they are.
replacers.
So I can tell you my experience. Meal replacement is very very effective, very effective if they are used correctly. I typically use meal replacement in people who travel a lot. Now, with COVID, we are all sitting at home. But there was a point when even I was traveling every weekend. And if every weekend you are going to eat from out, you know, you can never manage any reversal or even weight control. So, whenever people are traveling, people have jobs which make them stay out of the house for a longer period of time. I use meal replacement in all of them. And meal replacement is not same as protein shake. Meal replacement is a structured diet with 40% carbs, 20% protein, 30% fat. It is not whey protein shake which can be given.
Right. Ma'am, another question that we have is that is there any hope of reversal of diabetes when a patient undergoes bariatric surgery?
No, in bariatric surgery, it gets reversed on its own. तो हमको तो कुछ करना ही नहीं पड़ता because patient ही खाता नहीं है ना. See, if the patient has undergone
उसका
bariatric
side
surgery, yeah, any procedure, it doesn't matter whether you have done
gastric
sleeve or
sleeve.
you have done a switch or you have done anything. First side effect of bariatric surgery is hypoglycemia. तुरंत पेशेंट की शुगर नीचे आ जाती है within 2 days.
That's true.
Right.
And ma'am, how long can you recommend these meal replacers?
Well,
Are they
direct
forever?
trial has recommended it for 2 years now.
Okay.
Direct trial is in its third year. In fact, third year is about to end. So all
Yeah.
people on direct trial are on one or the other meal replacement. So that means 3 years
Okay.
they are recommending it. My personal opinion is I have recommended meal replacement for 3-4 years, but not every day. So whenever they eat out, they cheat or they cannot eat at home or whatever. So about 3 or 4 times a week, they'll end up taking one meal as meal replacement. Two to 3 times a week, they'll end up eating all the meals at home. So that is something I do.
Right. So, any more questions, Kalyani?
Shilpa, I wanted to ask one more thing. Like you said, meal planning, that means order of the day, that it has to be started with high protein diet. Can you share, more light? Can you tell us more about it?
So this is a very interesting concept. We all have been
Any more
using it.
questions? Ma'am, not that I have got any. I think
Can I answer this?
Kalyani, she's answering one question. Just wait.
So what happens is this paper is a very interesting paper published by Dr. Osama Hamdi from Jocelyn Clinic. What they have shown is when you start eating a meal, if you eat protein before you eat a carb, you really do not eat as much because you suppress ghrelin. Ghrelin is the hunger hormone. Protein suppresses ghrelin. अगर जो पेशेंट खाना खाने बैठता है तो सबसे पहले क्या खाता है? सलाद खाता है, राइट? दैट इज हाउ पेशेंट डज. पहले सैलेड खाते हैं, फिर रोटी विद होप के सैलेड से पेट भरेगा. यूजुअली व्हाट हैपेंस इज उस समय तो पेट भर जाता है एंड देन आफ्टर 1 आवर पेशेंट इज हंग्री बिकॉज ही सेज कि यार मैं तो सिर्फ सैलेड खाया ना, मैंने खाना क्या खाया. नाउ यू रिवर्स द ऑर्डर. यू स्टार्ट इट विद अ दाल. So you tell the patient कि भाई खाने के पहले ना एक बड़ा कटोरा, and when I mean बड़ा कटोरा, I mean the कटोरा from पंजाब, बड़ा, literally 250 ml वाला कटोरा. You give thick dal to the patient, या you give pulses, या you give any protein soy. उसके बाद पेशेंट को सैलेड देना और फिर खाना देना. ना पेशेंट खाएगा, ना पेशेंट को 2 घंटे 3 घंटे भूख लगेगी. So order of eating actually changes your
Yeah,
ghrelin
that's true.
response. And when ghrelin response changes, you see a lot of effectivity in a diet. इसीलिए the patients who are non-vegetarian will always tell you कि जिस दिन non-veg खाते हैं पेट भरा रहता है, veg खाते हैं घास फूस खाते हैं तो पेट नहीं भरता. It is not घास फूस which is causing them hunger. It is not eating protein in the beginning which is causing them hunger. वो चने राजमा भी पहले खा ले और बाद में चावल खाए तो भूख नहीं लगेगी.
Another question
Yeah,
which we have is related to yoga.
that's right. Thank you.
Is yoga effective?
Yoga is a long-standing drug. Remember, yoga works on your central nervous system. It actually decreases your sympathetic tone, and therefore, long term, if you follow it correctly, it takes time. It's a slow-acting medicine. It's like a lente insulin or a lente carbohydrate. धीरे धीरे काम करता है. But जो काम करता है वो पूरा पक्का काम करता है. That is why don't go to yoga class today and expect 2 kilos of weight loss tomorrow. But in 2 years, what benefit you will reap, you will never reap with any other exercise.
I think that is for everything. What we've eaten today will affect our tomorrow in a while. We must be sure that whatever steps we are taking, it can't just happen overnight.
No, but you
I
know
think
what,
all the
Dr. Kalyani?
participants should know this.
Yeah, what happens is patients ऐसा नहीं होते ना. Patients तो मैडम आपका ज्वाइन किया है तो आप 15 दिन में बताओ क्या हुआ.
Overnight difference चाहिए.
और तो 15 दिन में कुछ हुआ नहीं तो
Immediate
ऊपर नीचे हो जाता है.
magic.
हाँ, तो वी टेल देम ये तुम 100 किलो जो वेट लेके आओ वो एक रात में थोड़ी ना बढ़ा था कि एक रात में कम हो जाएगा. Then for patients you have to tell them.
That's true.
Exactly.
Exactly. That's the whole purpose of this particular webinar as well, that at least we are able to pass this message that let's take care so that we don't reach this particular stage where we are supposed to look for these alternatives. And that's the last question. And just a note for everyone, the feedback form has been shared. I request all the participants to please put in their name, designation, and institute correctly with their correct email ID so that the certificate can be generated to them. And I consider it a great privilege to present the vote of thanks. I, on behalf of the Department of Home Science, PGGCG 42 and IDA Chandigarh chapter, would like to take this opportunity to thank our worthy speaker, Mrs. Shilpa Joshi, who took out time from her busy schedule for such valuable insights. I'm sure our participants must have benefited immensely from this particular interesting and fruitful talk. A big thank you to our worthy principal, Professor Nisha Agarwal, for granting permission and for her continuous motivation to make us strive towards excellence. A shout out to our ever so active Dr. P.T. Sharda, librarian, for her constant guidance and technical support in helping us put this webinar together. Heartfelt gratitude to our IDA Chandigarh chapter convener, Mrs. Sunita Malhotra, and head of the Department Home Science, Dr. Manpreet Kaur, for their unflinching support and supervision. An extended thank you to Dr. Naveena and Mrs. Megha for coordinating. No webinar is complete if it had not been for our enthusiastic participants. So thank you one and all for your willingness and involvement in this webinar to make it a success. Please make sure that all of you fill in your feedback forms for your certificates. And I would just like to conclude by saying that the best and most efficient pharmacy is within our own system. So thank you, everyone. Thank you.
Thank you,
Thank you, Mr.
Kalyani. Thank you,
Joshi, and thank
Manpreet.
you, Shilpa.
And a big
Thank
thanks
you
to Shilpa.
so much for being there. It has been a wonderful session.
Yeah, yeah. So as usual,
Okay.
Shilpa is always the best. So thanks, Shilpa. Thanks a lot.
Yes, yes. Always. Always. Okay.
Okay,
Bye
okay.
bye and a happy Diwali to everyone.
Yeah, and happy Diwali to all.
Thank you. Happy Diwali.
Yeah. Okay.
Thank
Bye
you.
bye.